You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from the heart.org Medscape Cardiology, and this is This Week in Cardiology for August 27th, 2021. This week, COVID, a New England Journal of Medicine COVID vaccine safety paper, full dose anticoagulation in COVID, atrial fibrillation and exercise, and early results on the Emperor Preserved trial of empagliflozin. First up, COVID. There's not much change from last week. There is, fortunately, a deceleration in the growth of cases. I guess the bottom line is that given the utter unstoppability of this Delta variant, it's fortunate that we have vaccines. But we are in for a bad few weeks, I think. And the preventability of this amount of human suffering is really quite sad. Now let's talk about the New England Journal of Medicine vaccine study. This was an observational study in Israel on the safety of the Pfizer messenger RNA vaccine. And two docs have already come up to me in my hospitals to show me the study. They said, hey, Mandrola, you were wrong about the vaccine myocarditis signal. The study in the NEJM shows that myocarditis rates are higher with COVID infection than after the vaccine. And this matches some of the reactions I've seen online. But I think this interpretation of the study is wrong. The authors of the study matched a group of vaccinated people to unvaccinated. They then matched a group of patients who had COVID infection versus those that did not. Then they measured various outcomes, lots of things, from lymphadenopathy in the arm to brain bleeding to thrombosis. But the outcome of interest for most of us was the myocarditis signal. And they found a 3x increased risk of myocarditis after the vaccine, but an 18x risk after COVID infection. This led to the erroneous conclusion that the myocarditis signal from vaccines was overplayed and COVID is more likely to cause myocarditis. But the fatal flaw of that is that the authors did not stratify the myocarditis risk by age and or gender. Almost no one thinks the messenger RNA vaccines are unsafe for older adults. But there's a clearly concentrated myocarditis risk in adolescent boys and young men, especially after the second shot. It's much higher risk in males than females. So for that age group, the risk of COVID infection or hospitalization is very low. And all I am saying is that don't obfuscate the signal. Instead, let's study better ways to protect this group. For example, shouldn't we study one shot or different vaccine for this group? Let's also rethink mandates for this age group. It boggles my mind that we are going to force a 17 or 18-year-old kid to take 2 shots, go to college, or hold a job, given this CDC data. Also, the fact that New England Journal of Medicine lets this sort of paper out, knowing full well about the gender and age specificity of the vaccine myocarditis signal, tempts me to be cynical about science adjudication. I won't, but it tempts me. All right, next topic is anticoagulation in COVID. The New England Journal of Medicine has published a large platform trial concerning the use of full dose versus prophylactic anticoagulation in hospitalized patients with COVID-19. The platform part of this study is actually the combination of 3 trials, ACTIV-4, REMAP, and ATTACC. Now, the report was published in 2 manuscripts, one for patients with moderate COVID disease, the other for patients who were randomized in the ICU. This is very important work because hypercoagulability seems to be a feature of patients with COVID-19. And a higher propensity of clotting makes clinicians think that higher doses of anticoagulation would be helpful. And observational studies published in major journals indeed found an association between full-dose anticoagulation and better outcomes. But of course, regular listeners of this podcast know two important things. And one is that observational studies are limited by confounding and bias. It's very difficult, if not impossible, to adjust for all confounders. Two is that anticoagulation doesn't come free. It comes with major complications, and that is major bleeding. This is why you need randomization. So the moderate severity COVID-19 trial first. Again, these were 3 studies combined. The first paper included about 2,200 patients with moderate COVID-19 disease. One group was randomized to therapeutic anticoagulation, mostly with low molecular weight heparin, and the other with prophylactic low molecular weight heparin. 13,000 patients were screened, and about 11,000 were excluded for various reasons. And this is an important thing because it really applies to the application of this trial to real-world patients. And the primary endpoint of this trial is complicated. It was organ support-free days evaluated on an ordinal scale that combined in-hospital death, which was assigned a value of -1, plus the number of days free of cardiovascular or respiratory organ support up to day 21 among patients who survived to hospital discharge. Now, the outcome was evaluated with the use of a Bayesian statistical model, Bayesian, for all patients. There were no p-values. Instead, we get something that I love, the probability of clinical benefit given the data. It's not the probability of seeing the results or something more extreme given no benefit in the 2 treatment arms. That's a p-value. Here are the results. Of the 1,000 patients in the prophylaxis group, 76.4% survived until hospital discharge without receiving organ support, as compared with 80.2% in the therapeutic dose anticoagulation group. The adjusted odds ratio was 1.27, with credible intervals going from 1.03 to 1.58, meaning the odds ratio ranged from a 3% to 58% improvement in organ support-free days. The absolute risk difference was 4 percentage points. Okay, what does that mean? 76% versus 80% survival without organ support seems pretty close. And this is where the Bayesian analysis comes in. Remember, Bayes' theorem holds that the prior probability times the likelihood ratio of the data. The likelihood ratio is the probability of the data given the null divided by the probability of the data given the alternate. That yields the posterior probability. In this case, the authors used a weakly informative prior probability. They tell us that the posterior probability that therapeutic dose anticoagulation increased organ support-free days compared with the normal usual care thromboprophylaxis was 98.6%. And when they separated the analysis by high and low D-dimer, they got a 97% probability of superiority in the high D-dimer group and a 93% probability of superiority in the low D-dimer cohort. 7.3% of patients in the therapeutic dose group died versus 8.2% in the prophylactic group. That calculated to an 87% probability of superiority. Now for the bad news. Major bleeding occurred in 1.9% in the full-dose anticoagulation versus 0.9% in the usual care thrombophylaxis group. Now, I'll hold my comments until I tell you the results of the severe disease paper. This is the full dose versus prophylactic dose in the ICU. One important caveat here, standard prophylaxis was left to the discretion of clinicians. So in critically ill patients, 22%, 1 in 5 of the therapeutic dose group did not receive a therapeutic dose, whereas 52% of those in the control group received an intermediate dose, and this factor may have diluted any benefit of the therapeutic dose anticoagulation. This issue was somewhat less important in the trial involving patients with moderate disease, in which there was a little less overlap. In the ICU, it was the same endpoint, organ support-free days, about 500 patients in each arm. This trial was terminated at an interim analysis due to futility. The median adjusted odds ratio for the effective therapeutic dose versus prophylactic dose was 0.83 with credible intervals 0.7 to 1.03. Now remember that anything below 1 is actually worse, less organ support-free days. So that yielded a posterior probability of futility of 99.9% and a posterior probability that full-dose anticoagulation was inferior of 95%. A few comments. It is now 18 months into a pandemic in which millions of people have been hospitalized for COVID-19. And these heparin studies measured outcomes during a hospital stay. That's a matter of days, not years like most cardiovascular trials. So the first message is that it's sad that it took this long to study something so important and simple as whether to give full-dose anticoagulation. Now, the second message is that in May of last year, the beginning of the pandemic, the editor of a major cardiac journal was declaring full-dose anticoagulation a winner based on a fatally flawed observational study that showed a 200% reduction in death in patients on mechanical ventilation who received full-dose anticoagulation. And I'll link to my column on that study. Now, these RCTs utterly refute that observational study. In the RCTs, full-dose anticoagulation versus prophylactic anticoagulation in patients in the ICU had a 95% probability of being inferior. What a lesson. My friends, observational studies are not useless, but making causal conclusions about therapies from non-randomized comparisons is extremely precarious, and I'm surprised that leaders did this. Okay, the third message here concerns the magnitude of benefit in the moderately ill group. Yes, the probability of any benefit, even a 1% relative risk improvement, is 90+%. But the question clinicians want to know is, what is the probability of a clinically significant larger benefit, say a 10 or 20% relative risk improvement? I mean, cardiologists and intensivists, we don't usually accept drugs unless there's a 10 or 15 or 20% relative benefit. So the magnitude of benefit is critical because there was a doubling here of the risk of major bleeding with full-dose anticoagulation. And remember that the odds ratio was 1.27 for better organ-free support days. But the lower bound of that credible interval was 1.03, and 1.00 would be no better. So basically, this evidence is not very strong. If your prior was pessimistic, this data doesn't change as much. Roughly, if you felt the probability that full-dose anticoagulation had no effect was 75% before this trial, the data would only change that to a 23% probability of no effect. The fourth message relates to patient selection. This is really important. Recall that 80% of screened patients were excluded. This means the benefit of full-dose anticoagulation was reserved for a very select group. So in sum, regarding preventive anticoagulation in COVID-19, we can say, for sure, don't use full dose in the ICU unless there's a reason. But outside the ICU, in moderately ill patients, there is uncertainty. We have less than robust evidence for a large effect size in an ordinal outcome, little difference in survival, higher bleeding, and an unexplained difference in effect depending on the severity of the disease, and we also have strict inclusion criteria. So full-dose anticoagulation may benefit some patients, but gosh, clinicians will have to be super careful in applying these results at the bedside. All right, next topic is exercise and atrial fibrillation. At the ESC meeting, Adrian Elliott, an exercise scientist in the group of Prash Sanders in Adelaide, presented a small but elegant randomized controlled trial of structured exercise in patients with AFib. The clinical question was whether a structured exercise program would reduce clinical outcomes in patients who had symptomatic AF. And of course, observational studies associated cardiorespiratory fitness with less AFib, but observational studies here may be confounded because patients able to exercise may have less severe atrial disease. So the research team randomized about 60 patients to a combined supervised and home exercise program or usual care. The exercise program was tailored to patients' capability, and this included 4x4 minute efforts at 90%. It was progressively increased by 20% each week, and it was monitored with a detailed physical activity diary. The control group got a couple of education sessions and recommendations to do 150 minutes weekly of physical activity. The primary endpoints here were freedom from AFib and AFib symptom severity. And in the first endpoint at 12 months, AFib recurred in 60% of the exercise arm versus 80% of the control arm. The hazard ratio was 0.50 with a confidence interval ranging from 0.33 to 0.78, so highly significant. In the second endpoint, also at 12 months, there was a statistically significant improvement in AF symptom severity as measured by a questionnaire. As you'd expect, exercise capacity measured by VO2 peak modestly increased at 6 and 12 months, but there was no significant weight loss, blood pressure effect, or structural effects on the heart. Now, of course, with moderate exercise for only 6 months, you wouldn't expect big losses in weight or improvements in echo parameters. And there are limitations here, of course. The trial cannot be blinded, the effect size is small, and many patients can't or won't exercise. But my friends, this is a signal that if we try and we prescribe exercise and we exercise patients and not rush to ablate, we can help some motivated patients with an extremely safe and beautiful therapy. So congratulations to this group on this study. We look forward to the publication. The final topic today is Emperor Preserved, empagliflozin in heart failure with preserved ejection fraction. This big trial, along with a pooled analysis of Emperor Preserved and Emperor Reduced, will be presented this evening in Europe, which is about midday on the East Coast here in the United States. And I taped this podcast Friday morning before I go to clinic. I have only the preliminary slides from the press release, but it's such a big deal that I wanted to mention it on this week's podcast. Now remember, Emperor Reduced and Emperor Preserved were sister trials, very similar protocols, investigators, endpoints, statistical plans, and administrative structures. It was carried out in a similar time period, and they were separated by one thing, an ejection fraction of 40%. As background, Emperor Reduced studied about 1,800 patients with heart failure with reduced ejection fraction, EMPA-10, versus placebo, and it reduced the composite endpoint of heart failure hospitalizations and CV death by 5% in absolute terms and 25% in relative terms. The effect was driven mostly by heart failure hospitalizations. The 8% relative risk reduction in CV death was not statistically significant, and it was the same with overall mortality, numerically lower but not statistically significant. The Emperor Preserved trial studied approximately 6,000 patients with heart failure with preserved ejection fraction, again, EMPA 10 milligrams versus placebo, and it did reduce the composite endpoint of heart failure hospitalizations and CV death by 3.3% in absolute terms and 21% in relative terms. And again, the effect was driven mostly by heart failure hospitalizations, not CV death. The 9% relative risk reduction in CV death in Emperor Preserved was not statistically significant, and overall mortality was not different. The hazard ratio was right at 1.00. Now, a quick note before I say anything else. About a third of the patients in Emperor Preserved had an ejection fraction of 40 to 50%. That's important because these were not all completely normal EF patients. Both trials found that the effect appeared consistent in diabetics and non-diabetics. And in both trials, EMPA reduced heart failure hospitalizations across all ejection fractions, except for an attenuation in those with an EF of 65% or greater. Now, New England Journal of Medicine also published a second research letter on renal outcomes in the two trials, and this was called Emperor Pooled. The major renal outcome was a composite of three things: a sustained decrease in GFR of greater than 40%, or a decrease in the GFR to less than 10 to 15, or dialysis. And for renal outcomes, EMPA reduced major renal events and EMPA reduced, the hazard ratio was 0.51, but not in Emperor Preserved, hazard ratio 0.95. This clearly indicates that ejection fraction influences the effect of empagliflozin on the kidney. In the Emperor Pooled presentation, Dr. Milton Packer offered some comparisons to Paragon HF. Now recall that Paragon was a trial comparing sacubitril valsartan to valsartan alone in heart failure with preserved ejection fraction. The baseline characteristics in Emperor and Paragon were similar. The Paragon-HF trial randomized about 4,800 patients who were followed for a median of 35 months, whereas the Emperor Preserve trial randomized 6,000 patients who were followed for a median of 26 months. The incidence rates of the composite primary outcome in the control arm were pretty similar, 14.6% in Paragon and 12.5% in Emperor. But because Paragon had longer follow-up, it had a lot more events and thus more statistical power. In Paragon, the neprilysin inhibitor reduced the relative risk of the composite endpoint of CV death and total heart failure hospitalizations by 13%. Hazard ratio 0.87, the upper bound 1.01, and the p-value painful at 0.06. But in Emperor reduced the same composite endpoint by 21%, rate ratio of 0.79, and the p-value was 0.003. Now, Dr. Packer showed a slide and wrote up an editorial in Circulation showing a comparison across the two trials, which he admits is fraud. For the ejection fraction in the mildly reduced range, empagliflozin versus placebo had a slightly better relative risk reduction than did sacubitril valsartan versus valsartan. Well, my comments on this is I wish I had more time. Literally, I only have hours to think about this trial. In Emperor Preserved, I see a statistically robust signal of the composite endpoint of heart failure hospitalizations and CV death, which is an important endpoint. To date, no drug has proven effective for this endpoint in heart failure with preserved ejection fraction. So that is a win for empagliflozin. But there was not a significant reduction in CV death in either of the Emperor trials or overall death. Recall that in DAPA-HF, DAPA did reduce CV death in patients with heart failure with reduced ejection fraction. Now, we also learned that renal outcomes with empagliflozin were not reduced in heart failure with preserved ejection fraction, whereas they were in reduced ejection fraction. So my question is this: if EMPA is so great at reducing heart failure hospitalizations, why isn't it good enough to reduce CV death or overall death or renal outcomes? Was the trial too short? Would longer follow-up and the accumulation of more events strengthen the effect size? Or is this just a modest effect? The investigators and proponents are going to focus on heart failure hospitalizations and the composite, but clinicians and patients are going to have to weigh the value of a drug that did not reduce CV death or mortality or renal outcomes. I think for a patient with heart failure and an EF of 40%, EMPA seems quite reasonable. But for the extremely common elderly female patient with a small hyperdynamic LV and heart failure with preserved ejection fraction, probably not so much. Now, the other question facing clinicians is, in patients with heart failure with preserved ejection fraction, do we use EMPA or sacubitril valsartan? Because for many patients, not going to be able to take both, either because of cost or blood pressure. It'll force a choice. Now, you could go by Dr. Packer's analysis and say EMPA had a greater reduction in the composite endpoint. But of course, remember that EMPA was compared against placebo and sacubitril valsartan was compared against the active comparator of valsartan. Now, the tougher control arm may have blunted the response of sacubitril valsartan. We'll learn a lot from the DELIVER trial, which is going to compare dapagliflozin in heart failure with preserved EF. We'll learn whether this EMPA signal is a class effect. We'll learn whether one drug is a superior choice for heart failure with preserved ejection fraction or heart failure in general. In sum, looking at the vast health benefits in diabetes, in CKD, and now in both types of heart failure, the SGLT2 inhibitor drugs look to be a lot like the statin drugs. That is, a major breakthrough for the prevention of bad outcomes for many major organ diseases. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating. Write us a sentence or two review. That helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.